I'll kick us off and get us started. Um, Really excited for this conversation today. These are our monthly series, community conversations with CFHA. And it's January, new year, new you. It is a great time to be looking at, kind of different areas of your life and where you might want to make a change or things that you've considered. So we thought CFHA leadership thought this would be a great time to talk about careers and different options available to us in behavioral health and clinically. If you are not necessarily in behavioral health, maybe you are a medical clinician. So, what we're talking about today with our incredible panelists, if you're on this call, you should feel very privileged and lucky to get access to these folks on the call today. This is not an easy thing to do without a lot of networking. So, I'm really excited you all are here. What we're going to talk about today are clinical opportunities and jobs in behavioral health tech or in non-traditional fields. So when we talk about non-traditional fields, we're talking about things other than your traditional medical setting or behavioral health setting. A lot of changes happening, a lot of fast pace is happening with technology right now. And sometimes it can be unclear, how do I move into those roles? How do people get those jobs? What is it like? I have some experience working in two different venture-based startup companies. And my interest in this topic is because I was quite unprepared for that transition coming out of a federally qualified health center. I made the transition. I prepared as best I could for a new job, but I was really surprised at the culture shift. So we thought we would offer some opportunity to sort of learn more about that. If you're just joining, please throw your role and your organization in the chat. And if you have questions, please come off mute or throw them in the chat as we go along. I'm going to introduce our panelists. We have Dr. Shiri Sharvit from Resolve Together, CEO, and let me make sure I've got this going. CEO of Resolve Together and Distinguished Professor of Research at Palo Alto University. Dr. Julian Mitton, Head of Clinical Operations at ERA Supports. Giorgio Chatelain, who's an LCSW and the Clinical Director at Concert Health. And Sudhakar Kaushik, the founder and CEO of Jeevahealth. So a pretty heavy-hitting panel here. I'm going to ask each of our panelists to just briefly introduce yourselves, your organizations, and your backgrounds. And Julian, maybe we can start with you. Yeah.
Sure, happy to. Thank you, Stacy, and thanks everyone for hopping on and joining us. I'm really looking forward to this conversation. So I'm Julian. As Stacy mentioned, my current role, head of clinical operations at ERA Support, which is a venture-backed behavioral healthcare startup, specifically focused on supporting patients with substance use disorder in the community health center setting. I'm an internist and addiction medicine physician by training. I trained in Boston and spent several years working as a PCP and as an addiction specialist there, mostly in the community health center setting, as well as time in with the Indian Health Service in rural parts of the country. And then first transitioned out of clinical practice almost 10 years ago, more into the healthcare leadership and administration side, working for a couple large health centers, first with Mass General Brigham, where I completed training, and then with Common Spirit Health, which is a large Catholic-based health system. And then I won't get into the details now, but a little over 5 years ago, transitioned again out of the healthcare operations roles within health systems, and then really moved more fully into the new venture healthcare startup space. First as a consultant, and then now as a co-founder overseeing a clinical team at ERA. So happy to get into more of that today, but again, really looking forward to the conversation. Thank you.
Great. Thank you. Thank you, Julian, for that. Giorgio, do you want to go next?
Sure. Hi, my name is Giorgio Chatelain. I'm a clinical director at Concert Health. I'll give a little bit about my background in a minute, but just to let people know about Concert Health. So Concert Health is a behavioral health medical group that partners with primary care, women's health, pediatric practices to integrate behavioral health services using the collaborative care model based off the AIM Center. And so in that space, we essentially are looking at being able to use evidence-based practice to help reduce symptoms of depression or anxiety with our registry and being able to use evidence-based practices to be able to do that in a consortium with the primary care, our behavioral health clinicians, and our psychiatric consultants. A little background on me, I'm a clinical social worker by training. You might pick it up. I have an accent. I'm originally from Montreal. I'm of Haitian descent. I always kind of joke about that. But anyway, I'm based out of New York. I've been in New York for the past 20 years. I've been working in the field for over 20. And what's great about this conversation, like Stacy, I came into what we're calling the tech field really by accident. COVID hit, the world was falling apart. My daughter was remote. I needed some flexibility, and I entered into the space. And after being in the space now for the past 6, 7 years, I have a better understanding what it looks like, how to navigate it, understanding my skills as a clinician, but also then how it applies into a space that can be really different. In nonprofit, I did everything. And in this space, I realized that things are segmented in very specific ways of communicating and talking. So I'm looking forward for us to enter into this conversation.
Awesome. That's a great summary. Thank you. Sudhakar, do you want to go next?
All right. Thank you. Thank you, Stacey. I'm Sudhakar Kaushik. I'm based out of Raleigh, but originally from Boston and originally before that from India. Um, so it's been a travel, but I'm one of the non-clinical guys here. So I'm a technical guy that got into behavioral health primarily from the perspective of trying to fill a gap that I thought my family experienced dealing with clinicians in behavioral health as my children were going through challenges during COVID. So until then, I was happily working at Verizon and companies like that, running incubators for running in-house incubators. So I'm more of a guy that is in product development and launch of new products. And to me, when I saw a gap, it seemed to be an extension of what I would normally do in Verizon, which is, the clinicians here seem to work without the kind of data and insights they need for how the adolescents cope with issues. And I thought maybe I could do it. So what started as a small app that I thought I could give to my clinician that was treating our children turned into something that we were able to push into a pilot, and we have an adolescent focused and young adult focused product that's out with CYBHA in California. So my background is engineering, but I do have clinicians that I work with both from a therapy as well as psychiatry that has helped us build the product. So I'm very interested in learning from others here. I think I might have met Shiri before in my previous life. Not sure if she remembers, but I'm very new to CFHA, so this has been a wonderful thing, and I'm hoping to get as much out of the conversation as I can help contribute.
Great. Thank you so much. That's wonderful. And glad to have another perspective on the call. I think it's going to be really important as we get into it here. Shiri, last but not least.
Okay. Hi, everyone. And thank you, Stacey and Hannah, for the invitation for today. I'm Shiri Sharvit. I'm the CEO and co-founder of Resolve Together. I'm a clinical psychologist in my training, more than 20 years in the field. And while I worked as a psychologist, I always had an affinity to the tech space. So 20 years and evolved my career with the technology as it evolved. So 20 years ago, I worked in a startup that helped translate in-person teaching materials and didactics to online. Then I became a psychologist and was moderator in a parent forum online before Reddit and before Facebook, so it wasn't toxic. Then I moved to Stanford, and where I developed different chatbots and apps and Zoom-based interventions before the pandemic. And then I started more intensive work in the industry as the chief clinical officer of Ilios Health, a company that developed the first ambient AI progress notes for therapists. And I left that position a year ago to found Resolve.
Amazing. Amazing. Thank you all for being here. And we want this to be open to you all on the call. You don't have to sort of wait for me or the panelists. If you want to put cameras on, that's cool. If you've got questions for our panelists or about this transition or this field, if you've done that yourself, you can throw those questions in the chat or just come off mute anytime to participate. I think that there's some terminology here too. Venture backed is a new one, right? And of course, Giorgio, you're talking about, needing to stay in your lane, learning, right? That, but depends on what stage the company might be at. That might be new terminology for people. So if there's something that folks don't know, again, we can clarify any of that as well. I think one of the first questions to open it up to you all would be if you're coming from somebody with a medical or behavioral health background that worked in a traditional setting, hospital, outpatient clinic, FQHC, maybe individual therapy, what do you think was the biggest sort of challenge that you faced moving into a startup or a more tech-facing company? What was a challenge that you faced in doing that?
I can start.
Yeah.
I think I thought that Stanford was intensive in terms of the pace of the work. And I realized that in startups, everything happens so much faster. And you really need to report and up to your peers and update what's going on. And in research and in any behavioral health interventions, we're used to having long-term processes. You don't need to update every week. Oh, this patient's OCD has
Mhm.
improved by 0.005% from last session to this session. But and I was used to, receiving a task and updating once a week, once a month about on how it was developing. But in startups, you always have to update people all the time. And keep them really posted on where things are at and not wait for, the lab meeting or the team consultation meeting to discuss the status and reach out to them with questions.
Mhm.
Another point is the need to educate your peers all the time. Oftentimes, engineers and marketers, salespeople, people who are not in the field have some assumptions on what can be done. And I feel that as mental health providers, we need to remind them that AI, for instance, needs to be responsible and ethical, etc. I'm sure Sudhakar can provide his perspective on these type of conversations. And I think we can also learn from them, that sometimes you have hypotheses and try to test them out without the 95% confidence levels that we're used to having as providers and researchers.
Like needing to move a little bit faster without all the information, maybe, and
Yes.
all the,
Mhm.
yes, yes.
Yeah, as a psychologist, my language, my entire demeanor is much more cautious and
Yeah.
slow. And it's okay if we don't make a decision right now. We can let things, sink a
Percolate.
little and think about it. Let's revisit this next week. In startups, you need really to leave a meeting with deliverables.
Yes, all of that is so well said. Anyone want to jump on that? any of our panelists.
Yeah, I mean, I definitely second so much of what Shiri has shared. The other idea that comes to mind is just around the importance of sort of role clarity. And but how that has manifested for me is I think as a clinician, I was so trained to practice within a specific scope and to practice under a license. And when things started to creep out of scope, I would very quickly have the opportunity to turn to colleagues, experts, and sort of share as part of a multidisciplinary team. But really have a sense of sort of I had a very clear sense of what my swim lane was. A phrase that's already come up here. And when I transitioned into sort of faster space, non-clinical settings, I was increasingly asked to move outside of my comfort zone, outside of my swim lane, to really move into practice areas and bodies of work that I wasn't necessarily trained in or didn't have a certification or fellowship or residency training in. And at first, I was quite wary of moving in that direction. It's like, why are you asking me to be an HR rep when I haven't gone to school to be an HR rep, right? Because that was such a product of my training and of my background to date. So I think I had to be very flexible with moving into new spaces that I wasn't necessarily trained in and being transparent about that, but sort of moving with the flow quickly. So being okay in moving outside of my swim lane. And at the same time, also recognizing that those around me who didn't have the same background that I had were way more comfortable with jumping out of swim lanes. And in some
Mhm.
ways, I also had to play this additional role of making sure that people were not stepping into spaces that I really feel like they didn't have the appropriate sort of background or perspective. So to get granular here, especially folks in non-clinical backgrounds making recommendations, judgment calls about clinical spaces and not saying no to them, but just like learning that it's important to contextualize and recognize that there's a diversity of perspective. So I think that was my takeaway was just the flexibility around role and being astute and aware around how other people are coming in into that multidisciplinary space.
Great.
What
Thank you.
was,
Go
oh,
ahead.
sorry, I was gonna say what was interesting for me, Julian, is coming from being a leader in nonprofits, is that
Mhm.
my lane was all over the place. I did everything just because
Mhm.
they can really pay us to have like specialists in anything. So I took care of finance, I took care of operations, I took care of clinical practice. And I didn't realize it until I came into this like tech space where I was told to like be in a very particular lane, but I knew about a bunch of other things too, right? And so I knew more about operations than I realized until I got into the space where I had to like learn how to speak language differently.
Mhm.
And then there was like the whole part about translation for me, right? Where I felt like when I first walked into a hospital, I had to learn a bunch of acronyms. I got used to that. I got comfortable with it in outpatient clinics. And then I came into this tech space and I learned about KPIs and deliverables, just a different way of talking about certain pieces than I was used to. And to your point, Tree, the idea of teaching people, I take it as also as understanding everyone's language and like finding a common one. We're all coming at a problem from like different angles and like not being able to understand what um, I, my engineering and tech team always laugh at me because I'm always like, it's super simple. Just create a button for it. Like, can I just like have one click and then laugh? And or if I talk to like finance and we're talking about the pressures that we're having in terms of being scalable and like moving forward, or even like thinking about what scalable looks like versus my experience in FQHC, it was how do we deal with the rush or intake of new need and demand, which was less different than how do we scale so that we deliver across the board. It was just kind of a different way of thinking and looking at some of those pieces. And all things I had to get used to, one in learning language or learning how to work with others to be able to kind of translate and figure out how we have some common viewpoints on it. Um, advocating for the experience that I had by also learning. So for me, it was like I wanted to like swim out of my lane or actually speak to the experience that I had, right? Like this wasn't brand new for me. I've seen it just from a different like vantage point. And being able to kind of do that and learn that conversation. Um, and getting used to different business ends that are coming in this space where we can still do great work, provide great pieces, but knowing that we were seen more as a service and a product as opposed to when I was in a clinic where we all were about service, period. That was like the beginning and the end of what we did. But that's some of my experience.
Yeah, that's great. Product versus product to work to apply the word product to what we do. That was challenging. That was the difficult pill for me to swallow. I feel differently about it now, having spent some time. Thank you for that, Samuel. I saw your hand. I don't know if you want to, and we see your question in the chat. I don't know if you want to come off mute and ask it. If not, I just want to listen to.
I see his, yeah, I see his question here. I could talk to
Yeah.
it
Oh,
too.
he's coming. I'm
Yeah,
sorry, Sudhakar. He's coming
go for it,
off
go for it,
mute.
go for it. Yeah.
That works for me. Sorry, y'all walking. I'm actually a student here, so commuting towards class. But one of the things in my experience right now is searching for jobs, right? So trying to just understand when we talk about this language, what can be a barrier, or we talk about the experiences, what would you all say is what I need to be kind of crafting right now, the roles, the spaces I need to be placing myself in to build experiences that would make me a valuable candidate one day.
Great
I, I
question.
don't, I don't know if he's a student in the clinical area or a student in engineering. Sorry.
He said, oh, go ahead.
I'm clinical. I'm PhD student in medical family therapy, East Carolina.
Fantastic. Could
Yeah,
I
go
could add
ahead. Go
some,
ahead,
yeah.
please.
Let me add some perspectives because I'm itching to react to what Shiri was saying and Giorgio and Julian as well. More from the perspective um, as an entrepreneur as well as an engineer and a product builder, what it takes. The product building for me was very easy because I came from Verizon where we were running incubators, which meant we were launching products pretty traditionally in a particular set fashion. The challenges for me were to be able to transfer that expectation with clinicians around us. And so the requirement from a startup or from an engineering perspective always is very in our minds, at least in the engineers' minds, at least, is pretty clear. And the hypothesis, the view that we take on hypothesis is this is something to be tested. If it fails, we switch. So the
Hmm.
ability for us to move from one hypothesis to another is very fluid. Um, so our perspective on certain things, I think one of you mentioned is less than complete information or less than complete testing. So there's a slight distinction. There's less than complete information to be able to build out a feature, yes, but there is less than complete testing would lead to disaster, typically, in even in engineering setting. So if we had a Verizon internet service offered and it fails without a full testing, then it's a customer disaster, right? So, so entrepreneurs and engineers tend to have the view that a feature needs to be built very quickly to be able to see if a customer would accept it, if a product would fly. But by the same token, we also want to make sure that the customer experience that we have talked about or we set the expectations around is something that we would have to deliver. So that is something that would also be how we would approach, for instance, the responsibility of building clinical knowledge sets to drive our product, as an example. So we would take also building the responsible AI as an example as well, which I think Shiri was raising. So every one of the approaches from a clinical standpoint for us is we are looking to the clinicians for expertise. We are
Mhm.
looking for them to be able to tell us what we are doing stupidly, which is quite often the case. Because we are making the assumption that a product feature, as long as it incorporates a clinical knowledge set, as an example, is is predictable. especially from an engineering standpoint, we expect that if these are the symptoms and the diagnosis is just directly correlated. So there's an aspect of probability associated with how we would set up our responses in our logic, for instance, right? There is less of a human interpretation on the fly in any of our product definition. So there is a design for the product, and the engineering thinking always is if it is designed to deliver X output, then we would just rig it up to be that, and there we go. One of the biggest learnings for me when I had therapists and psychiatrists on our team to try to build our products out was that there is so much of interpretation that happens on the fly, even for the same set of screening data, as an example. There is so much of subjective evaluation that happens when you're delivering a service in a clinical setting, clinical service. That is not how an engineering product is designed. So there is a lot of allowance that we have to be able to build in to be able to let clinicians make the call, to be able to let clinicians make the interpretations, let clinicians actually sign off on the decisions that we do. That's such an important aspect of how an engineering product has to be designed in a clinical setting that I had to learn quite a bit about. And there is also the subjectivity of an app in the hands of a 16-year-old in Tufts, 18-year-old in Tufts University in Boston. We did a pilot at Tufts and BU in Boston. BU, in fact, was for addiction. And versus the same product in Seattle, in the University of Washington, and in California, when we did it with Berkeley students, the responses were very, very different. The demographics were different. So there was so much of what we had to do, be able to come back and feed back to the clinicians. That's when we really know, the engineering gaps and the clinical gaps. So setting up a knowledge base with clinicians' help wasn't adequate. And when we had to pivot, it was a very hard thing for clinicians to come along to that kind of mindset.
Hmm.
Most clinicians do not appreciate the concept of a quick 3 week, 4 week sprint, pivot. They would rather settle for a 3 month, 4 month kind of plan.
Hmm.
I think that was a little bit of a education back that I had to share with the clinicians because the mindset for clinicians always is little more, I should say, not entrenched, but it is set in the way the services are delivered in clinical settings. Whereas a
Yes.
product has to fly very quickly. A product has to adapt so quickly. So there's a lot of mutual learning and knowledge transfer that I think can happen to each other's benefit. But outcome, as long as we are centering everything around patient outcomes and clinician quality and clinicians' ability to drive those outcomes, I think we are pretty golden in that sense.
Thank you. Thank you for that. Giorgio, I see you came off mute, but I do want to circle back to Samuel's question, which is a tactical one of what kind of skills should he be cultivating right now? Where should he be placing himself? Who should he be talking to? If anyone has ideas on that.
I was gonna hit on that. First, I want to say
Great.
that as an engineer, hearing you talk like that is super reassuring.
Yes.
Especially the part of recognizing how there's diagnosis, and there's the presentation, but then there's all these other pieces and variations that happen in the moment that you're assessing for that you can't always predict.
Yeah.
And also then how that plays out with experience, right? Like with clinical experience. So who the clinician is, how much experience, how much they've seen the thing also then changes how they assess and do. And now going to kind of Samuel's question is, I think appreciating that we are the clinical experts in the room and in the space, and that our voice is necessary and needed in order to help steer and guide clinical outcomes or groups. I think that's important. One of the things I talk to a lot about clinicians is finding their voice as their clinical experts. And I work with a range of different clinicians and so it just kind of changes their own confidence in it and what's happening. So I think that part is really important. Um, depending on where you are, I know Samuel, you're a student, so there's knowing that part and learning the language of what it looks like to do clinical delivery. I did not understand what operations was until
Mhm.
I was in a place where I had to define operations very differently, right? Like the levers that have to be pulled, even using the word levers was very different than a space that I was in. And so there's learning the clinical interventions that you're doing and then learning about what clinical delivery looks like from a more um, business point of view, whether it's running a clinic or in a hospital. What are all the pieces that go into making it happen, right? So from the moment the patient walks in, what are all the places that they have to go to be able to get to that intervention or that part, the things that work, the things that don't work. If you're in clinics right now, paying attention to all the different levels that a patient's journey they may go through in order to really get to the place where they're being served or seen. I think those things are really helpful in terms of if you want to walk into the tech field and you want to be able to speak to the work that you do and want to deliver in a different way. Those are some of the things that might be helpful. But I'll let some of my colleagues share.
The only thing I would add is I found it during the interview process when I was trying to get into the tech field that they would increasingly ask me to talk about like a project that I got my hands dirty in and like being able to talk about it in detail and be very clear around what the problem was, what the solution was, how we uh, evaluated it, how we pivoted quickly. So rather than necessarily talking about my training and my
Mhm.
skill set and my background, which is again like what I've been so encultured to do, it was really more about tell me about a time when there was a solution that you leaned into as a result of a challenge that you faced in your clinical practice, and be specific with me. So my thoughts are, it's like, yes, there are training opportunities out there. There's opportunities in coaching and sort of like learning about roles and language and how to understand data and how to manipulate it. Like that is valuable and there's value in that skill set. But I think what is also important is sort of having a set of projects that you can speak to and sort of really highlight your involvement in. And ways to get that as a student and as a junior staff member or even further along in your career is just get involved with what's going on in your practice setting. If there are needs around EHR changes, if your practice setting is thinking about partnering or working with a new venture, get involved in that process. Sort of
Mhm.
immerse yourself in these small little micro projects that are happening in your practice setting already, and that might be the opportunity for you to then speak to that experience of sort of working a project along and getting your hands dirty.
That's great. That's great advice. I love that.
Yeah.
Shiri.
Yeah, I think really great suggestions were made here. I just want to highlight to Samuel and to other people here that there are many more entrepreneurs, engineers, salespeople who are interested in working in digital health tech than there are health providers. Therefore, your skills, your expertise, your intuition are very much in demand in this field. There's a great Slack group called Therapists in Tech. If you can
Yes.
find it, I'll try and post the link here, but if you can find it, you can uh, send me a message on LinkedIn where they post positions for clinicians who are interested in getting more expertise or working in the digital health domain. A lot of these places have or workplaces have are remote, so it's not for everyone. But I think it's a really good opportunity to be in that group, learn what other people are building, the kind of questions and dilemmas that people share in that group. I think it has more than 3,000 clinicians on it, and it's free to join. But
Yes.
remember that the skills are highly needed. And as was mentioned here before, this integration and collaboration between people with lived experience, people with professional experience, and people who are interested in contributing to the field, this is what will make progress.
Yeah,
Yeah,
that's super helpful. Sorry, let me just jump in here. I want to sort of highlight a little bit of a different piece of this and why I wanted to kick this kind of a conversation off. For those on the call that are not in these settings, and maybe you're in outpatient or you're receiving government funding, which most of us are for to our organizations, I think it's important to kind of look at, even if you are not interested in moving into a role here, that folks that are in startups and sort of that tech forward realm are increasingly involved in healthcare and increasingly involved in decisions made at the government level for funding and how things work. So, without getting too deep into the politics that we've seen or the partnership between President Trump and Elon Musk is a tech guy and came in and did some things that were very much in line with how sometimes startups can work, right? Sort of what are we looking at? Efficiencies, cutting things here and there, moving quickly. Now, we can debate how that all went, but if you just take away the piece of for-profit folks being involved in healthcare, I think it's important that we on this call and in this field sort of get a little more comfortable with how that looks and that pace of things and those terminologies so that we can be at the table, so that things are not imposed upon us, and our professional identities are sort of like swept aside for folks that are a little more comfortable with making those decisions, right? So I'm glad you're all here today, and I wanted to sort of plug that even if you don't want to move into these fields, I think it's important that you're here and that we start to get a little more comfortable. Thank you, Shiri, for putting the therapist in tech on the chat, so you can see that there. Any other comments, or I know Sudhakar, did you
yeah.
want to build? Yeah.
I would like to add to the comments made here from an engineering perspective in terms of what we would typically like to see from clinicians. The core clinical expertise is highly valued. Their expertise and experience when and that's very important because that's where we generally do the translation between how a product needs to be built and what needs to deliver as well as it can to be able to support the clinicians as well as the users, right? um, so being that sort of an expert is just the number one background that we would look for. But I think there is another aspect though, which is I think Julian was referring to it, which is if you had typical operational settings, typical clinical settings, typical service settings, has a team approach in terms of actual delivery of a service. And within a startup, however, we would like complete ownership for each people. So when we talk about, how dirty did you get your hands in your previous project, or how complete was your ownership? The whole intent is to be able to really understand if somebody could stand certain projects up on their own and take complete ownership of it and deliver it end to end with some inputs from engineers, with whatever. In our case, for instance, if I had to have a knowledge set for the clinical knowledge base that we were creating for us for our chatbot to be able to go deliver, dip into the knowledge base and be able to do certain things, we expected the clinician to be able to actually lead that from the perspective of, okay, this is what the knowledge base should be able to really take in as input, put out as output. Now, engineering things can be schematically very easy to point out what it does, what it's looking for, what it's looking up, et cetera, et cetera. But we want that ability because that helps the clinicians, and I mean that helps the product guys and the engineers to be able to go draw up things on the whiteboard and say, hey, here are all the things that I would expect the clinicians to be able to contribute. Do you think that's possible, right? And um, when clinicians also take a role where they are looking at, okay, here's the protocol for how we would deal with this. That actually is not something that a product in a behavioral health tech field may allow us to do.
Mm-hmm.
If it is an independent standalone product, we cannot rely just on protocols. We have to be able to rely on, is it offering up enough of that sort of an outcomes or outputs that a clinician can make a judgment based on that, and then can you run with it? So that's the expectation, is if I'm creating a dashboard, and is the dashboard analytics sufficient for a clinician to work off of? Right. So the perspective that engineers have is very highly, what should I say? It's efficiency driven, but it's also very probabilistic. We tend to think that a certain input can give a certain output. And that is something that's fundamentally different when we are dealing with human subjects, especially in a mental health perspective. And that core expertise ultimately resides in the minds of these clinicians that can help the startups develop those products and services. So for them to be contributing to a startup or a tech industry within a behavioral health setting, that is the mindset that they still need to have, is the ability to be able to bridge how an engineer thinks and how they design versus how a clinician can think and actually offer the equivalent of that is a point of sale experience in a Target store, right? Ultimately, that's what the clinician needs to be able to really bring that perspective into how a product can actually deliver that.
Yeah, I think that's well said. I think this may be a little bit of what you're talking about, and something that Giorgio, you mentioned, something that I struggled with in the first organization that I transitioned to was sort of being very quick and direct about my recommendations. So I had learned how to make recommendations in previous roles, but I learned how to sort of bring people along with me, right? As clinicians, we're sort of, I think we're trained to teach and let people kind of come to their own conclusions, especially patients, right? We don't want to impose anything. We talk about you could do this, right? Or maybe we want to kind of share what you were saying, right? We sort of want to like give some time. And in some of these early meetings, I would see all of the clinical folks, myself included, meet with our engineering team. And you could just see the engineering teams, the finance teams glaze over as we were all talking for a really long time. When someone would ask us a yes or no question, should we do this? And we would explain kind of all the reasons why we should or shouldn't. So I couldn't figure out what was happening, right? But I was sort of losing credibility, and our clinical team was losing credibility because we were just like not communicating in the way we needed to for people to understand. So I'm wondering if our panelists can maybe Shiri start with you. Kind of how did you find your voice? What do you think you did to kind of maybe get your recommendations out there faster, say things before you were 100% confident, kind of that process?
Okay. Um, so fortunately for me, I had some studies before that where I needed to interact with TV channels and
Mhm.
podcasts and TV shows and morning shows. So I got very early on the feedback that no one wants to hear the long intro, how this treatment was developed in the 1970s, etc.
Yep.
What the general public is expecting are really sharp, clear yes or no answers with very clear takeaway message. So I was able to sharpen these skills very early on in my startup career. I started in research that was more academic, but once I left Stanford and moved to the industry, it was clear that I'll need to translate the the methods and everything that was developed. Ford started in the 19th century, right? So, but all the background is not necessary.
Mhm.
And it was really clear for me that in order to be heard, it's not enough to be in the room where it happens and where people make the decisions. I also need to learn how to communicate things effectively. I do want to say also that gender roles are also important. As a mental health provider, these, stereotypically feminine traits of talking more slowly and reaching a more collaborative decision are not highly valued in a
That's right.
fast startup space. You'll find yourself very often the only woman in the room. Um, and I needed to adapt to the type of conversations. Also, I learned something that probably was necessary even before, but that politics is also important, and
Yes.
um, uh,
Yes.
the decisions are not necessarily made in the room in the time of the meeting. They're often made outside in the more non-formal spaces, by the way, spaces that sometimes women are not invited to. So you'll have to be ready for that. Um, and I can talk about my experience. I'm sure, immigrants or people of color feel similarly. Um, so really learning how to speak clearly, how to reduce all the fluff and all the extra uh, text in order to really provide sharp answers that are clear for everyone. And sometimes you'll need to reiterate and repeat the same topic over and over again. For instance, uh, my previous company developed ambient AI progress notes, and being the salespeople, they said, yeah, someone will a therapist would submit their notes earlier, and they will have time to see another client, another patient. And I was like, no, you probably haven't worked in healthcare in the US. No, these people already in community-based clinics, they have a caseload of 40 to 70 people. They have 28 to 30 direct care hours. No, they're just gonna save their pajama time and submit their progress notes on time and go home and spend time with their family or just stare in a blank wall, but that's fine. So these are the type of conversations that sometimes you need to reiterate over and over again.
But how important that you were in the room, right?
Yeah.
Because that salesperson goes then to the leadership. The leadership is like, sounds good, and then imposes that on a team. So that's awesome. Thank you for that. Julian, did you want to jump in?
Yeah, just really quickly, some other practical tips and thoughts on this topic. One thing I found particularly helpful is really grounding when I'm trying to communicate in specific case studies, and even bringing up or sort of bringing the audience through a patient journey. So like really grounding it in something that is practical rather than hypothetical. My second thought is like really avoid getting into the academic esoterica, which is something again that I was comfortable in, but really be thoughtful around summarizing data and studies for the audience. You don't want to lose them when you're getting into study design and epidemiology. Then the third thought, I hate being the person to recommends this, but like use your favorite AI tool as a friend here in translating what you're trying to communicate for specific audiences. I found it to
Mhm.
be very helpful in sort of taking notes and taking content that I've tailored for a clinical audience and adjusting it to a marketing or engineering audience. Don't take it verbatim, but as a practical skill and step in that translation process, these tools can be pretty effective and helpful.
That's awesome. Thank you. Thank you so much for that. We have a few minutes left. I want to just point to there's a survey in the chat. If you're on the call today, you've joined. I set up a survey. CFHA is interested in potentially rolling out some support for folks who may want to make this transition into non-traditional roles. So we'd love to hear from you and get your thoughts on that. If you could take that survey, it's very, very quick. There's only 4 or 5 questions. Does anyone from the group, not a panelist, have any questions or anything that you would like to hear from? I just want to open up for that. maybe what your hesitations are, or if you've taken any steps in this direction.
I have a question.
Yeah, thanks.
I'm curious about I guess in a general sense, the longevity of some of these roles. If we were to be in a position where we're providing our clinical expertise, once a program or software has that, are we then needed anymore, or are these sort of temporary positions?
Oh, that's a great question.
Um, I can speak to a little bit of my experience in it. I
Yeah.
think some of it, the other learning is like figuring out where a company is at, like what different places startups are. Is it like in the infancy, adolescence, or adulthood? And I've been making a clinical as to where it's at, because then that changes in terms of
Hmm.
longevity, not because your role is not important, just because companies pivot really quick and they move rapidly. And if it's profitable or not will shift
Mhm.
or spot. And so one of the things that I've learned in my pivot is how I'm always planning next steps, not because I'm not valuable, just because of what that role in that place of that company may look like. It may shift or change, because they have to like pivot and try new
Mhm.
things. I worked for Headspace for a bit,
Mhm.
and they've had to like shift a lot in terms of where they started versus where they are. Working at Concert Health, we're scaling, so like that changes the parts of it. If the question is, will the tech world take all of our expertise and once they have it and they program it, then we're not needed? I
Mhm.
don't really see that, to the point that was made before, where there are all kinds of variables that you can't program for and that you can't see, right? Like there's all kinds of places in the moment, in the space, that you can, and we're always shifting and developing in terms of as people, as we're navigating the world and like new things are coming in, that I
Mhm.
think our value will always be there. Obviously, I'm a clinician, so I believe in us. Um, Also, so just know that there's always a space and place for it.
Mhm.
And Shiri was talking about it before. Representation matters, and so you need as many varied voices in different
Mhm.
spaces as possible in order to make sure that there's representation at every level. What's going on? So just because there's a couple of us in the room doesn't mean that represents everyone. And so the more varied voices that you have, then the more that the products actually start improving. And I know I'm calling it a product, but that's really probably what it is. And if we want to make sure that, I always kind of try to think about it also from a social justice piece of it. Where's the equitable part of it? How does it get applied? Who is it going to impact? And so there's always going to be space for us to be able to speak to that.
Awesome. Thank you.
I,
Shiri,
I,
oh, I'm sorry. Yeah, go ahead.
I would totally agree. I think those are excellent points. I think the role for a clinician is invaluable. They don't recognize how valuable that is and how it continues to be valuable. But there's one distinction that I would call out is Headspace originally was a service company. And in that sense, I think anybody that's clinician that's just looking for a role in a company that's semi-tech, but really more of a service company, then the scalability is just having more people and just using you no differently than a service or a clinic would use. But a product company would always have a need for that kind of role because, especially as we evolve, the gaps haven't gone away. The fundamental problems and the structural problems that we have in the mental health industry has not gone away. It's gotten worse. And the politics doesn't help either. So there's plenty of opportunities for making that kind of impact. And I'm a firm believer that tech can actually help clinicians to be able to make that impact. So I'm one of the few people that look at tech as it's a tool. Although I'm an engineer by trade, by training, I always look at it as how does it serve the customer? Because that's what Verizon trained us in. And that's the same, I would think, most successful product companies in health tech space are always going to take that approach is how do we position this as a tool, AI included, tech included. If anything, I think their point is that there's going to be a lot more emphasis under the new CMS guidelines. There's a lot more emphasis for health tech, especially some of the gaps that I think clinicians can help is they really care about outcomes. but they don't have the time to be able to go get those outcomes done and track and make sure it happens and is consistent and the adherence and follow through is good, et cetera. So there's so many different ways that clinicians can actually contribute from ideas and clinical expertise to make products better and impact better. I don't see that going away. And the stage of the company that Giorgio was talking about, beautiful example, because your role is very vast and very complex in a small startup. Your role could tend to get a little more defined and pretty contained as you go into a larger company.
Great. Thank you. Thank you so much. We are just about out of time. Does anybody have just a last quick thing they wanted to throw in? Okay. All right. Well, thank you all so much for joining today. Thank you so much to our panelists. Really appreciate it. Please reach out if you have more questions on this topic. And I hope you all have a good rest of your day. Thank you so much.
Thank you, Stacey.
Thank you,
Thanks,
everyone.
Thank you.
Stacy. Yep. Bye-bye.
Bye.